Good evening, everyone, and thank you all for joining us for our webinar this evening, which is the first of a series of presentations that will be delivered on the subject of substance use, funded by the Sydney North Primary Health Network. Thank you very much for your patience. My name is Catherine Mills. You can't see me on screen at the moment because we're just having some technical difficulties, which I apologise for, but you can see Chris, which is the important person for the presentation. As I said, my name is Catherine Mills, and I'm an Associate Professor and Director of Early Intervention and Treatment Research at the Centre of Research Excellence in Mental Health and Substance Use at the University of New South Wales, at least for the next few days, after which we are moving to the University of Sydney and will be called the Matilda Centre next week. But I have the pleasure of facilitating this webinar tonight, which will be presented by Dr. Christina Morell. Before we begin, I'd like to start by acknowledging the traditional custodians of the land and also to pay my respects to the elders, both past and present, and extend that respect to Aboriginal and Torres Strait Islander who are present here today. As I mentioned, we have an exciting series of webinars that will be conducted over the next 12 months, and this is the first webinar which will provide a basic overview of substance use in our community, identifying commonly used substances and their effects. But just before we begin, I'd like to just draw your attention to the Q&A button, which is on your screen. Please feel free to click on that button and type in any comments or questions that you might have at any time during your presentation. And we'll have 10 to 15 minutes at the end of Christina's talk for discussion, when we will go through these. If you experience any technical issues during the webinar today, you can call the technical support line with the details there on the screen, or visit the Zoom support webpage and chat online with a staff member there. And I'll also put this information under the Q&A or chat function so that you can find that at any time during the presentation if you need to. And we are recording this webinar, so if you'd like to view it again or download the slides as handouts, you can access them at the website on your screen. And lastly, please remember to complete the CPD assessment at the conclusion of the webinar. You can do this if you're watching the live webinar or a recorded version until the 4th of May 2019. So now it is my pleasure to introduce Dr. Christina Morell, who is a Senior Research Fellow at the Centre of Research Excellence in Mental Health and Substance Use. Her research aims to improve our understanding and treatment responses to co-occurring substance use and mental conditions, and particularly among complex populations that have multiple chronic conditions who often require a range of health and social services. Christina's work is built on a strong collaboration with clinicians, consumers, carers and other key stakeholders. And a big part of her work focuses on translating research findings into evidence-based resources for clinicians and the community.
Thank you, Kath. And thanks so much everybody out there for joining us for this webinar tonight. As Kath said, the focus of our webinar today is on substance use in our community, identifying commonly used substances and their effects. So although, as Kath mentioned, the webinar today is the first in a series of 8 webinars on substance use, which we'll be presenting over the next 12 months, you don't need to have, and you don't need to attend all 8. Our intention is really to provide enough information that each of these can stand alone. So if you're just wanting to have more information on substance use, you can just come along to tonight's webinar. So there'll be a little bit of overlap between some of our topics. I also wanted to mention that a lot of this information won't be new to many of you out there. We're really intending to provide as comprehensive an overview as we can in an hour. So please forgive us if we're telling you things that you already know, and bear with us until we move on to the next slides. And finally, there's a few hyperlinks in this webinar. You won't be able to click on these throughout or during the live webinar or the recorded webinar, but you should be able to link to this content using the handouts, which will be available at the end of the recording or the end of tonight's session. So before we get started, I just wanted to quickly run through the learning outcomes for the webinar today, which are to have an improved understanding of commonly used substances, their effects, and what to do if use is suspected, have a better understanding of how to identify substance use and how to discuss this with patients, and have improved awareness of where to access more information. In terms of what we'll be covering in the webinar, we're going to follow these learning outcomes quite closely. So I'm going to first give an overview of what some of the commonly used substances are, including how they present, what they do, and what to do if use is suspected. I'll then talk a bit about how to identify substance use and how to address or discuss this with patients. And then I'll finish up by providing some suggestions for where more information can be accessed. And just before getting started, I wanted to mention that so far I referred to alcohol and other drug use primarily as substance use. There are lots of different terms that are used, often interchangeably, to refer to substance use. And I just really quickly wanted to mention some of these here because there can be quite a bit of confusion around terms and different people using different names to refer to the same thing or completely different things. So the term illicit drug use is often used to refer to problematic substance use, but this in itself can be quite problematic because we know that the most harmful substances, alcohol and tobacco, are not illicit. So psychoactive substances is often a commonly used term, and this can either refer to any drug that alters the functioning of the body, or depending on the person using it, might only refer to substances that have a psychotropic effect, such as hallucinogens, for example. So during the webinar tonight, I'm going to either be talking about substance use, meaning the use of any drug which alters the body's function, either physically or psychologically, or alcohol and other drug use, or AOD. So firstly, I'm going to be giving a brief overview of some of the most commonly used substances in the Australian general population, what they do, and what can be done if use on some of these is suspected. I'm going to be asking a range of questions throughout our workshop today, starting with this one here. So let me just launch our first question. So in the general population, what do you think the most commonly used substances are? And this is based on the most recent National Drug Strategy Household Survey, which was conducted in 2016. So you can select 3 of the following options. Do you think in 2016 the most commonly used substances were over-the-counter prescription, painkillers and analgesics, cannabis, alcohol, tobacco, heroin, methamphetamines, ecstasy, or new and emerging psychoactive substances, or illicit substances? So I'll just leave this open for about 5 more seconds, so feel free to jump on in and select your responses. And they're still coming in. Okay, I'm just going to end that now. Cool. So quite a range of responses. Okay, so in the general population, the most commonly used substances in 2016 were actually alcohol and tobacco, with a much smaller proportion of the population using illicit substances. Of the illicit drugs, the most commonly used were cannabis, followed by smaller proportions who use methamphetamines, ecstasy, cocaine, hallucinogens, inhalants, heroin, synthetic cannabinoids, ketamine, new and emerging psychoactive substances, and GHB. And again, small proportions use non-prescription pharmaceuticals, including analgesics, tranquilizers, steroids, methadone or buprenorphine, and other opiates. Well, when do we need to become concerned about a person's use? Is it really, do we need to be responding to any use, or is it only when a person develops a use disorder that we should be thinking about intervening? So we know that not everybody who uses will develop a use disorder, and recent analysis that we've conducted here indicates that the most addictive substances are stimulants and opioids, with up to an estimated 1 in 2 people going on to develop substance use disorder after first use. And this is then followed by sedatives, alcohol and cannabis, with more than 1 in 3 likely to develop use disorder on these substances after first use. But it's really important to note that while many people drink or use at high levels without meeting criteria for a disorder, they may nonetheless be at risk of harm. In terms of how long it can take for a person to develop use disorder, our work has shown that half of the cases of sedatives and opioid use disorder are observed around 2 years after first use, followed by cannabis and stimulant use disorder at around 3 years after first use, then alcohol around 4 years after first use. So it's really quite quick. I'm going to ask another polling question of everybody here. Let me just launch it. Okay, so in terms of who might be more likely to develop a use disorder, who do you think are the people pictured on this slide, and you should be able to move that around your screen, is more likely to have a substance use disorder? Do you think it's person 1, person 2, person 3, person 4, person 5, person 6, person 7, person 8, or person 9? So I'll give you about 10 more seconds. Sorry to rush you all. think maybe a couple more coming in. Okay, and just 2 more seconds. Okay, I think everybody on that slide got a vote. Okay, so some of you are right. So statistically speaking, number 5, the young man in the suit is more likely to have a substance use disorder. But of course, having said that, it's really important to remember that anybody can develop a disorder, which I think this really clearly shows. I really wanted to also make mention that there's often a lack of recognition of substance use disorders because of assumptions about what a person who uses will look like. And I'll get into that a little bit later. So I won't go through all of these substances in detail, but I have listed most of the more commonly used substances here, as well as what they are in terms of a stimulant, depressant, sedative or hallucinogen, the common forms in which they're usually accessed in Australia, how they're commonly administered, as well as how they're usually sold. So the idea behind this is if somebody presents talking about having bought a point of something, then you'll know what they're talking about. Many of these substances, so for example, cocaine, methamphetamines and ecstasy can be cut or mixed with other unknown substances, which of course will affect the purity and also the effect of the substance. So on this slide, we have cannabis, ecstasy, cocaine, hallucinogens and methamphetamine. And on the next slide, inhalants, heroin, ketamine, GHB and benzodiazepines. This might be something that you would like to come back to at the end of the webinar and go through in a bit more detail. So I will go through a few of these drugs in a little bit more detail, not all of them, unfortunately, because we just don't have time. So just to get started, I'm going to ask another polling question here, and there's not that many more. Can you identify which substance do you think these slang terms are referring to? Do you think that it is ecstasy, cannabis, heroin, methamphetamines, nitrous oxide, codeine, or magic mushrooms? There's a bit of a clue on the slide itself. So I'll just leave it open for another 5 seconds. Great. Okay, so I think most people got it right. The answer is heroin. So there was a poppy plant on the slide. Heroin and other opiates are part of a larger family of drugs called opioids, the most well-known being methadone and oxycodone. As I had listed in our substance overview table, the most common form of administration is injection, but it can also be smoked, snorted or heated, and the vapors inhaled, and this is sometimes referred to as chasing the dragon. It's usually sold in caps, which is quite a small amount, usually enough for 1 injection or a shot, or grams. It can be sold cut or mixed with a range of unknown substances, which can make it really difficult for a person to know the purity of what they're taking, and also, of course, the other substances that it's mixed with can be really harmful. Heroin and other opiates are central nervous system depressants. The effects of heroin include an almost immediate rush, small or pinned pupils, feeling drowsy or out of it, feeling relaxed and content, followed by feeling quite sedated, euphoric or high, detached, nausea or vomiting, dependence, including withdrawal if use is stopped, coma or overdose, and including death. Some of the physical health risks associated with heroin use include the risk of blood-borne viruses and endocarditis, which relate to the method of use rather than the drug itself, lung infections and overdose. And some of the long-term risks include dependence, dental issues, which is often due to opioids leading to dry mouth and less saliva to prevent tooth decay, but also dental hygiene and diet. People who use heroin are also at increased risk of dying from suicide and trauma. And some of the psychological health and social risks include breakdown of relationships, problems with employment, school or study, and homelessness. There's also an increased risk of social isolation, mainly due to heroin being really highly stigmatized. There are risks associated with the method of administration, which is usually injection, so skin and vein infections, endocarditis, and blood-borne viruses, as I mentioned, as well as the risks associated with the other substances that heroin can be cut with. Overdose is more likely to occur with heroin than any other drug. So as I mentioned before, it's a CNS depressant, and accidental overdoses are common, particularly when other depressants are used. So for example, with alcohol, benzodiazepines, or other opioids. Combining heroin with some kind of antidepressants, for example with tricyclics, or stimulants such as cocaine or methamphetamines, can also increase the risk of overdosing. A person is also at risk of overdosing after periods of abstinence, so for example after recent prison release or long-term abstinence-based treatment, if they have previously overdosed and if they use alone. The signs of overdose include extreme drowsiness, or the person may be impossible to wake, pinned pupils, slowed breathing and heart rate, cyanosis, usually starting on the lips and fingers, low blood pressure, a drop in body temperature to below 35 degrees. But if caught in time, the effects of overdose can be reversed with naloxone, but there is still the risk of serious health problems such as pulmonary edema, bronchopneumonia, nerve problems, kidney or brain damage. In terms of what you can do if you suspect one of your patients is using heroin, one of the most beneficial things is to promote a harm minimization approach. And these same principles apply for all of the substances that we'll be talking about today. So for example, the best way of avoiding harm is not using it all. But if use does happen, encouraging the person to not use alone, smoke or snort rather than inject, use clean injecting equipment, not use heroin with other substances, and advise patients to carry naloxone and be trained in its use. So there is evidence that peer groups play a really central role in the development, delivery and scale-up of take-home naloxone in Australia. There are agencies and services who provide take-home naloxone training to users and peers, and there's more information about some of these in the resource section at the end of the webinar. As you may know, naloxone or Narcan was rescheduled as an S3 over-the-counter medication in 2016. It's really easy to administer. It's available in a pre-filled syringe for intramuscular injection or in ampules, and it should be available as an intranasal spray sometime in 2019. One of the more common treatments that has evidence demonstrating its effectiveness for heroin dependence is opioid substitution treatment, and this includes methadone, buprenorphine, Suboxone, and naltrexone. Other treatments include residential rehabilitation, and this involves a stay at a drug-free treatment agency after completing detoxification. These programs can be quite short, so for around a month, or longer, 3 to 6 months, or even longer than that. Counselling and withdrawal management are other forms of treatment. And evidence from longitudinal cohort studies tell us that positive outcomes are associated with long-term stable treatment. We also know from these studies that detoxification is useful as a gateway into other forms of treatment, but isn't really necessarily a treatment in itself. We'll be talking about AOD treatment options in a later webinar. So we're going to move on to our next substance, and you can see from the slang names on this slide that it is methamphetamines. So methamphetamine is a synthetic stimulant that's manufactured from laboratories, manufactured in laboratories and chemicals, including those used in colds and flu medications. Methamphetamines is part of a larger family of drugs, which also includes amphetamine and ecstasy. So amphetamine was quite common in Australia until the late 1990s, when it was replaced with methamphetamines. Highly purified methamphetamine can have quite a translucent crystalline appearance, which is known as crystal or ice, which is not usually cut with other substances, but it can still contain impurities from the manufacturing process. The powder form of methamphetamine is typically diluted with adulterants, usually glucose or sucrose, and this can result in a lower purity. The effects come on quite rapidly within minutes if smoked or injected. Snorting or swallowing produces a less intense high that can take up to half an hour to occur, and this includes dilated pupils, talkativeness, increased confidence, inability to sleep, reduced appetite, dehydration, rapid heart rate, restlessness and agitation, paranoia, and hallucinations. There are quite a range of physical health risks, which include weight loss, poor dental health, cardiovascular problems, kidney problems, lung problems, infective endocarditis, skin sores, and the risk of blood-borne viruses, which again, similar to what we were talking about with heroin, is primarily due to the route of administration rather than the drug itself. Mental health risks include dependence, paranoia or hallucinations, depression, anxiety, agitation, and irritability. And longer-term risks include impaired brain function, which can manifest as poor concentration and memory, poor ability to regulate emotions, and also movement problems. So the evidence suggests that the best outcomes are associated with structured psychological and behavioural therapies, so for example with cognitive behavioural therapy and contingency management. Other treatment options include detoxification, residential rehabilitation, and outpatient counselling, with the best outcomes associated with people continuing their treatment beyond attending detoxification. So as with what I was talking about in relation to heroin, people who stay in treatment longer are less likely to relapse. Dexamphetamine pharmacotherapy has been available through the New South Wales Stimulant Treatment Program, but there isn't necessarily any conclusive evidence as to its efficacy. So I'm going to move on to our next substance, which is new and emerging psychoactive substances, or the very catchy acronym NEPS. There are many terms that refer to new or emerging substances. I'm going to talk today about new and emerging psychoactive substances, which refers to substances which are not controlled by UN conventions, but have similar public health threats, and as well as psychoactive substances which are relatively new to the drug market. So the terms synthetic drugs and legal highs can be quite confusing when they were used to refer to NEPS, because many traditional illicit drugs like LSD, methamphetamine and MDMA are also synthesized, and many countries, including Australia, have made these substances illegal, even though some are still legal at an international level. NEPS can also be referred to as research chemicals, analogues, herbal highs, designer drugs, novel psychoactive substances, or bath salts. In Australia, synthetic cannabinoids are the most widely used NEPs, followed by stimulant and psychedelic NEPs. The effects of NEPs are quite wide-ranging and really depend on the chemical composition of whatever is being used, but can include agitation, nausea, hypothermia, cardiovascular problems, tachycardia, organ failure, seizures, psychiatric problems, metabolic acidosis, and paresthesia. In terms of whether NEPs are legal to use in Australia, this is quite a complex issue. So most Australian jurisdictions have tried to keep up with the rapid growth in the number of NEPs by introducing blanket bans on possessing or selling any substance that has a psychoactive effect, excluding alcohol, tobacco, and food. Others have been caught in this complicated cycle of playing catch-up, where specific NEPs are banned and additional substances are regularly added. But this is actually a really good example of how substances can be harmful regardless of their legality. So what to do if one of your patients is using NEPs? So as with all substances, the best way to avoid harm is to avoid using them. But if use does still happen due to the ease of accessibility, the fact that they don't necessarily show up on drug screening tests, and the fact that they're sometimes sold as traditional substances, so for example, cocaine, LSD, or ketamine, the best option is to take a harm minimization or reduction approach. So encouraging the person not to use alone, not to be the first person in a group to try a new or unfamiliar product, starting off with a small dose, waiting at least an hour before consuming the intended dose or redosing, using only one drug at a time, letting somebody know what you've used, and avoiding NEPs in cases where there are pre-existing cardiovascular conditions. So I'm going to move on to our next substance, which is benzodiazepines. I'm going through these really quickly. I apologise. Hopefully you'll have time at the end to come back and review the slides. As I'm sure most of you know, benzodiazepines are commonly prescribed for a range of problems, including anxiety and insomnia. They're usually prescribed for short-term use due to their dependence liability. As benzodiazepines are depressants, their immediate effects are associated with feelings of relaxation and sedation, as well as decreased heart rate and respiration, slurred speech, blurred vision, confusion, and blackouts. If they're used over the long term or not as prescribed, some of the risks include dependence, aggression or violence, particularly at high doses among those with a history of aggression, overdose, and sedation. Some of the other risks include the cumulative effect of polysubstance use, particularly depressants. So for example, using benzodiazepines along with alcohol, antihistamines, opioids, tricyclic antidepressants, gabapentinoids, or antipsychotics, which means they need to be really vigilant about other substances that are being used, even if they're not being prescribed by one prescriber. Also being aware that abrupt cessation of benzodiazepines can lead to withdrawal seizures, therefore taking care to manage or taper withdrawal in line with current RACGP practice guidelines. So our next substance is cannabis. So cannabis comes from the cannabis plant. The active ingredient is THC, and the potency can vary quite a lot between plants. As I mentioned earlier, cannabis is usually smoked in joints or bongs, although it can be, actually I didn't mention it, but it was on the slide, sorry. So it's usually smoked in joints or bongs, although it can be eaten. You sometimes hear people talking about hash brownies, cookies, or lollies. The short-term effects of cannabis include a feeling of well-being, so feeling talkative or drowsy, a loss of inhibitions, decreased nausea, increased appetite, loss of coordination, dryness of the eyes, mouth and throat, increased anxiety or paranoia. Some of the long-term effects include increased risk of respiratory disease, decreased memory, concentration and learning abilities, decreased motivation in study and work, risk of mental health problems, and risk of dependence. In terms of the treatments that are available for cannabis dependence, the research shows that in comparison with minimum treatment controls, psychosocial interventions reduce the frequency of use and the severity of dependence, at least in the short term. So among the included interventions, an intensive intervention provided over more than 4 sessions based on the combination of motivational enhancement therapy and CBT with abstinence-based incentives was most consistently supported for treatment of cannabis use disorder. In terms of pharmacological interventions, there's a lack of really good quality research available to help guide clinicians. There is some potential for preparations that contain THC, but this is where more research is needed. Gabapentin and N-acetylcysteine also look to be promising, but the efficacy is unknown. It also appears that antidepressant, bupropion, buspirone, and atomoxetine don't have a lot of evidentiary support at this point. There are roughly about 1 in 20 people who misuse pharmaceuticals, and the most commonly misused are prescription or pharmaceutical opioids. And these, in a nutshell, are medications which are commonly prescribed for acute and chronic pain and include morphine, pethidine, codeine, oxycodone, methadone, hydrocodone, fentanyl, and buprenorphine. The non-medical use of pharmaceutical opioids refers to any use outside a doctor's prescription, and this can happen when they're taken orally outside a doctor's instructions, as well as if tablets are snorted or crushed, dissolved, and injected. So a person can obtain pharmaceutical opioids in lots of different ways, so through a legitimate prescription from a doctor, purchased on the illicit market or over the internet, by theft, family and friends, or by visiting lots of different doctors. The immediate effects of all opioids include analgesia and euphoria. Other effects are also associated with normal doses and include nausea, vomiting, respiratory depression, constipation, drowsiness and confusion, and at inappropriately high doses, respiratory depression and circulatory failure can also occur. As with all other medications, adverse effects are more likely when they're taken outside the guidelines for safe and effective use. Particularly overdosed if high doses are used, opioids are injected or combined with other sedating medications such as alcohol or benzodiazepines. And there's also the additional risks associated with injection if that's how they're administered. In terms of treatment for pharmaceutical opioids, the evidence tells us that methadone and buprenorphine can be used and have been shown to be effective. And as with heroin and other opioid dependence, long-term stable treatments are associated with positive outcomes. No difference has been found in terms of treatment retention or opioid use between methadone and buprenorphine, and other factors such as patient preferences, stigma, logistical factors, and potential drug interactions will likely determine which treatments are better suited for individual patients. So I'm going to move on now to our next substance, which I talked a little bit about at the beginning of the webinar and was the most commonly used psychoactive substance in 2016, which is alcohol. In 2016, more than 3/4 of Australians aged over 14 reported using alcohol in the past 12 months. Alcohol is commonly and mistakenly thought to be a stimulant, mainly due to the fact that the initial effects included reduced tension and inhibitions, relaxation and excitement. But alcohol is actually a CNS depressant. After tobacco, it's the leading cause of drug-related death and hospital admissions. The effects of alcohol vary and depend on gender, size, age, mood, medical conditions, and whether it's consumed with other substances. Some of the harms are associated with drinking too much on one occasion, such as accidents, injuries, unsafe sex or alcohol poisoning. Others with regular drinking, such as liver disease, cancer or dependence. The major risks associated with alcohol use include immediate problems, such as increased risk of experiencing an accident or injury, so for example, through traffic accidents, falls, fires and drowning. And this risk is particularly or especially high among younger people. There's also an increased risk of sexually transmitted infections or unintended pregnancy, an increased chance of experiencing violence, so for example, getting into fights or being assaulted. Longer-term problems include alcohol dependence, brain damage, cardiovascular, cancer and liver problems, increased risk of mental health problems, diabetes and obesity, and risk of fetal alcohol syndrome if alcohol is used during pregnancy. So I'm going to have another poll here, and this one is asking a little bit about alcohol facts and myths. So which of the following will speed up the rate in which alcohol is processed through the liver? Is it cold shower, exercise, black coffee, fresh air, vomiting, all of the above, or none of the above? So I'll just leave this open for about another 10 seconds or so. Okay, and I'm going to close it. Last votes. Great. Okay. Well, the answer is that sobering up takes time. So none of the above, none of these will increase the rate at which alcohol is processed by the liver. The liver can only work at a fixed rate, taking about an hour to break down alcohol in a standard drink. A trick question, I'm sorry. So here I have a version of the Australian Drinking Guidelines standard drinks. And if you'd like to see this for yourselves, you can access it at the website on screen there and download it. I would like to ask our final polling question for tonight. And this is asking, in Australia, one standard drink is one drink poured in a bar or restaurant. Is it 100 mils of beer, wine or spirits? Is it 10 grams of pure alcohol or none of these? And I'll just wait another 5 seconds for the final votes to come in. And last votes. Okay. Now it sounds like it would be a trick, but a standard drink is a drink that contains 10 grams of pure alcohol. So as I'm sure you know, there's wide variability in how much alcohol different drinks contain, but it's not a trick. So in 2009, the NHMRC released national guidelines to reduce the health risks from drinking alcohol, which were informed by research conducted to determine the lifetime risk of alcohol consumption for acute injury and chronic disease. So this research found that having 4 standard drinks on a single occasion more than doubled the risk of injury, which then increased by 1.3 times for each additional drink after that. Drinking more than 2 standard drinks a day increased the lifetime risk of death from alcohol-related disease by more than 5-fold for men and 6-fold for women. So although these are technically still the current guidelines, the alcohol guidelines, it's really important to note that NHMRC alcohol guidelines are currently undergoing revision and suggest that based on information from the World Mental Health Surveys, risk is increased from as little as 1 drink per day. So the updates will likely include risk at low levels of drinking. There are also additional challenges associated with trying to address drinking, and I started to touch on these a little bit earlier when I mentioned different terms which are used in relation to substance use. So one of the major challenges is that alcohol and drinking is culturally normalised and promoted through various mediums, and as alcohol are major sponsors of many Australian sporting events, drinking is often associated with a really healthy and sporty lifestyle. People often talk about drinking socially, even though this can represent daily harmful levels of drinking, and there tends to be widespread perception that just because alcohol and drinking is socially acceptable and even bonding behaviour in some circumstances, and it's not stigmatised like heroin, for example, it isn't harmful or causing damage. So this view can also be perpetuated by some healthcare providers where they accept descriptions of social drinking or use as non-harmful or not very much. So in terms of what to do if somebody presents with problematic or harmful levels of drinking, some strategies include encouraging patients to attempt a period of abstinence from drinking, such as through Feb Fast, Dry July, Sober October, Hello Sunday Morning, or other similar programs. There has been a small amount of research evaluating the effect of these programs, and this has found the majority of people who've taken part reported health benefits, with more than a third who reduced their alcohol intake consumption, maintaining this change for at least a year. So other useful strategies include publicly available resources such as online or telephone interventions for mild alcohol disorders, but specialist services may be needed for more severe dysfunction. In general, there's been relatively low uptake of the approved pharmacotherapies for alcohol relapse prevention by GPs, for example, naltrexone and acamprosate, which is thought to be related to limited opportunities for GPs gaining practical addiction experience through training and clinical placements, as well as limited ongoing access to addiction medical specialist support. And then this can have a roll-on effect in terms of low confidence in managing alcohol problems and hesitancy in prescribing available pharmacotherapies. Just to summarise the key points of what we've covered so far before moving on, there are numerous types of substances that are commonly used with varying effects, and the effects can often depend on the method of administration as well as other types of substances that can be cut with a primary substance. It's a really good idea to try to maintain awareness of the different types of substances that are used in the local area, as well as some general harm reduction strategies. And also be mindful of where to access substance-specific information, as well as management and treatment guidelines. And this is something we'll be covering in detail in a later webinar. So I know I've only talked about a few substances in this section, but I'm going to now move on to talking about how substance use is identified and some strategies that might be useful in addressing it with patients. Before we get to this section, I just wanted to start off with a case study and introduce you to Elizabeth. So Elizabeth is a 42-year-old finance manager who presents to her GP complaining of insomnia. She has tried relaxation techniques before bedtime and she used to exercise regularly, but since a recent car accident, she hasn't been able to very much. I'd just like you to keep these very few details about Elizabeth in your mind as we progress. I'll come back to Elizabeth as we move through the process of screening and identification. So obviously there are a lot of things that we need to assess when we're going about identifying substance use, and ideally a holistic approach should be taken which assesses a person's overall situation, their home and family life, employment, housing, physical and mental health. It's also important to note that the person may not present specifically in relation to their substance use, but in relation to other conditions, and details about their substance use may come about incidentally. But here I'll just briefly talk about substance use and how this can be identified through an informal assessment process and standardized screening and assessment. And again, this is just a really brief snapshot of how substance use might be identified. If you're interested, I'd recommend you look at more in-depth training. So the informal assessment should be in the form of a semi-structured interview in a non-judgmental, empathetic, private and confidential environment. If there are any limits to confidentiality, so for example with coerced patients or in juvenile settings, these should be explained. Components that should be covered in the informal assessment include mental state and AOD use history. And as I just mentioned, identifying AOD use is really just the first step. There's a lot of other information that you would want to collect in addition, which is covered in detail in the National Comorbidity Clinical Guidelines, such as risk assessment, strengths and weaknesses, and readiness to change. So we won't go through these components tonight, but you can find more about these by clicking on the link on screen there, which I can see is cut off a little bit. I'm sorry about that. At the end of the webinar, you should be able to access that on the handouts. A crucial component of the assessment process is evaluating the patient's mental state and their presentation. This isn't in a series of direct questions, but is based on an overall evaluation of the patient during an assessment, or preferably several assessments. A record of the mental state examination should be completed after rather than during conversations with a patient. And as well as noting any abnormal or unusual patient behaviours, it's also quite good practice to record normal behaviours. So for example, no speech disturbances noted, no unusual thought content noted. So I've put a link here to a form that might be useful in guiding or in helping guiding note-taking for the mental state examination. The mental state is not a separate examination. It's part of what you're already doing. But things to pay particular attention to include appearance, behaviour, speech and language, mood and affect, thought content, perception, cognition, and insight and judgment. And these things can give you an idea about a person's physical and mental health. They can also give you an idea or give you an indication of whether the person is intoxicated or withdrawing. In terms of a patient's appearance, consider how they look. Is there any evidence of their AOD use? How are they behaving? Are they talking and expressing themselves? How do they describe their emotional state? What are they thinking about? Are they experiencing misinterpretations of sensory stimuli? And does their attention fluctuate? It's also important to gain an understanding of the range of substances currently used, the quantity and frequency, duration and circumstances of use, any previous AOD-related problems, risk behaviours related to use, and previous treatment or attempts to change, and why these were successful or unsuccessful. So clinicians should also try to gain an understanding of the development of the patient's AOD use over time and include any periods of abstinence and how these were supported. And also ask about the use of any non-traditional or new and emerging psychoactive substances. Some healthcare workers can be reluctant to question their patients about their AOD use, primarily for several reasons, and this can include concern that asking about AOD use will disrupt and potentially damage rapport, the belief that patients may be unwilling or not ready to change or address their AOD use, the belief that patients won't disclose their use anyway, in which case there's not much point asking about it, the tendency for many physicians and the public to treat substance use disorders as acute disorders that are self-inflicted, a lack of knowledge and or confidence in how to respond to use if it's reported, assumptions that certain patients are not using AOD, the lack of recognition of the signs and symptoms of substance use, tendency to be skeptical about the effectiveness of interventions and therefore pessimistic about long-term outcomes, and of course lack of time. So the tendency to view substance use as self-inflicted and to remain pessimistic about long-term outcomes remains in some clinicians, despite some similarities in the treatment of substance use disorders and other chronic medical conditions, such as asthma and diabetes, for example, comparable levels of adherence to recommended treatment, and also evidence that available treatments are as effective as for other chronic medical conditions. If patients are asked directly about their substance use in a non-judgmental way with open-ended questions within a therapeutic relationship, they are more likely to talk about their substance use. The practitioners can access information to help them respond to a patient who reports problems with their substance use, for example, through the Australian Drug Information Network or ADN for information on services. Some examples of ways to ask about substance use include asking open-ended, non-judgmental questions such as, can you tell me about your alcohol or drug use in the last month? It can also be helpful to ask a patient to describe a normal day to help them try to evaluate the ways in which their substance use affects their health, their relationships, legality, and livelihood. So for example, their finances and their work. And more detail about the typical day can be found in the hyperlink on screen there. Some examples of ways not to ask about substance use include making judgmental statements such as, don't you know the harm you're doing to yourself? Or making assumptions about the person in front of you, such as, you don't use substances, do you? So in both of these examples, if a patient does use substances or is considering whether or not to disclose any use, an approach like this is likely to make them shut down and not reveal any substance use. It's also important to remember that anyone can develop a disorder. There's often a lack of recognition of substance use and mental health disorders because of assumptions about what a person with these disorders might look like. So I've put some general do's and don'ts that can help guide practitioners when talking about substance use with their patients. And these include some of what I've covered in the last few slides and include do, ask open-ended questions, quantify the amount of substance use, probe for more specific details, ask about the circumstances of use, be empathetic, be alert and considered. Don't be afraid to ask questions, use stigmatizing language, ask leading questions, or express any judgment. It's also important to remember that a lapse isn't necessarily a relapse. Lapses are a normal part of the process of recovery and don't necessarily mean a person is where they were before. So if a lapse can be identified early enough, a relapse can be prevented. So next I'm going to talk about standardized screening and assessment. In addition to the informal assessment process, there are a range of standardized screening and assessment tools that can help clinicians gather data on their patients. And these provide a really reliable and valid view of the patient's difficulties and current life situation. And when they're done or when they're conducted appropriately, they can be quite a good way of building rapport. Standardized assessments should be completed upon entry and exit from treatment, as well as at follow-up. And test results can provide useful clinical information for both the patient and the clinician on the patient's case and an evaluation of how effective their treatment has been. So a variety of different tools could be used, some of which are empirically established instruments, whilst others are purpose-built, internally designed tools with increased practicality and utility, but unknown validity and reliability. When conducting a standardized assessment, it's really important to provide the patient with the reasons for the assessment and the purpose of each instrument, explain its standard procedure, explain how standardized assessment can be useful in helping patients achieve their goals, for example, by providing an objective measure, and provide appropriate and timely feedback of the results. Standardized tools cover a range of areas which may be relevant to services with substance use patients. So some of these require specialist training, or else mislabeling, misinterpretation, or inappropriate use can occur. Some tools are copyright protected and need to be purchased and/or require the user to have specific qualifications. Some are self-reporting, meaning they can be self-completed by the patient, and others need to be clinician administered. Another resource which clinicians might find useful is Mark Deedy's 2009 review of screening and assessment tools for use in AOD settings. And this includes a really comprehensive overview of all screening and assessment measures, where they can be accessed, whether there's a cost involved in their use, details of their reliability and validity in AOD settings, as well as their strengths and limitations. So this is free to download from the Network of Alcohol and Other Drug Agencies website, the NADA website. I've put a hyperlink to it on the slide there. Although it's 2009, so it's almost 10 years old, it's just really great. It's comprehensive and I use it all the time. Some substance use instruments that might be useful include the CAGE questionnaire, and this assesses problem drinking, the Michigan Alcohol Screening Test, or the MAST, which assesses lifetime problems with alcohol use, the Drug Abuse Screening Test, the Alcohol Use Disorders Identification Test, or the Audit C, which is a briefer version of the audit, and the Drug Use Disorders Identification Test, or the DUDIT. More information about these can be found in the Deedy review using the link on the previous slide, or through the list of resources which I have at the end of the webinar. So going back to Elizabeth, when her clinician asked about the range of substances she was using, she described having used prescription opioids after her car accident to help manage her pain. She had dislocated her knee badly and had required surgery and rehabilitation following the accident. Although she was prescribed opioids at first, once these ran out, she began taking some of her mother's pills that were left over from her hip replacement. When Elizabeth was asked if she drank any alcohol, she said she didn't drink very much. But on further inquiry, when asked how often and how much she drank, she described she was drinking every day, and the amount she drank had increased from 1 glass of wine with dinner to 1 bottle each night. She spoke of having nightmares about the accident and found it hard to sleep with the pain in her knee. The clinician also asked about Elizabeth's AOD use history, and she described having used cannabis several times, but not since her teens. She hadn't received any treatment. Elizabeth was given the audit to complete, and she scored 12, indicating hazardous or harmful levels of drinking. So this example highlights the need to ask detailed questions regarding substance use and how both informal and standardized techniques can be used to ascertain this kind of information. So finally, I'm going to finish up by providing some links to additional sources of information. So I have a list of resources and links here that I hope you'll find useful. So there's more information on specific substances, the RACGP practice guidelines, which you probably already have, but the National Comorbidity Guidelines, some screening tools and assessments, some information on monitoring drug trends, take-home naloxone training and where to find more information about that, facts about alcohol and other drugs, an evidence-based online toolkit for methamphetamine, and a resource on language. And to sum up all of this information in a nutshell, substance use is common, It's important that substance use is identified so that it can be managed and treated appropriately. And there's a lot you can do in primary care settings to identify and manage people who are using substances. So I just wanted to thank everybody for having joined us for this webinar. If you would like to complete the CPD assessment attached to this webinar, you can click on the link on this slide once the handouts have been made available, and remember to submit your responses. We'll be making the recording of the webinar and the slides that you've seen today available online at the at our Vimeo site there. And you can also join us at the next webinar, which is going to be on the 12th of February. We will be having a discussion on substance use and physical health, and you can already register for that webinar now. I will put the link to register on this slide here. I meant to do that before, I apologise. And we'll have more information on the rest of our webinar series throughout 2019 coming soon, so stay tuned for that.
Thanks so much, Chris.
Thank you.
We do have about 5 minutes left to ask a few questions that have come up from the panellists attending. Mm-hmm. Firstly, some of them are comments, I guess, as well. You mentioned the importance of sort of doing standardised and comprehensive assessments for substance use, because otherwise it may get missed if it's not directly asked about. But someone had also mentioned that the reverse can also be true, where because a patient presents with a known history or quite obvious substance use perhaps, that clinicians can miss potentially underlying physical health conditions and instead sort of misattributing it to a person's substance use or withdrawal from that use.
Yeah, absolutely. I think that's a really important point. It's so important to look beyond the substance use, I guess, to see what lies beneath and think about the physical health and mental health too. And just on that, we will have a webinar upcoming on physical health, so very timely comment. And also we will have one on mental health and substance use as well coming up next year. I'm not sure on the exact date yet. Something else too that I was thinking about as you were saying that is that a lot of people who do present with substance use problems do actually have legitimate pain. I know that, we talk often about people going from doctor to doctor to, find prescriptions and try to, drug seek. But I think that we sometimes forget that a lot of people who are doing that actually are, experiencing a lot of pain that just isn't being appropriately managed.
Yeah, definitely. That's a really, really good point, I think. And as well, something sort of related to that, because I guess that there's that comes down to some level of stigma as well that's associated with people who might be seeking quite legitimately scripts for pain that they're experiencing, relates to stigma. And I think I saw it flash up on your screen there. A new resource that's been put out by the Network of Alcohol and Other Drug Agencies in collaboration with NUA about language and how important language is in working in this field. Because I think, and I think that's a really helpful resource, because I think many of us are very mindful of stigma, but even if that is the case, sometimes we inadvertently perhaps use language that we don't realise might be further stigmatising to people. So when I saw that made me think of that as a very good and a recent resource that has come out too.
Yes, that just I believe came out this year. I think that's also another really important point. And language changes all the time, and what we think is appropriate language at one point is quite offensive later, and you're not necessarily intending to be stigmatizing or discriminating, but it might come across that way. So
yeah, and especially when you hear,
to be mindful of.
Yeah, probably everyone has those stories of people that you like are coming into the clinic, and it might be the first time that they're sort of ever disclosing facts about their use, and the difference between someone who does has a non-judgmental approach and just sort of a discussion with people versus someone who's had a bad approach or a felt judged or stigmatised in any way, it can so severely affect their pathway from then on about whether or not they go on to seek,
engage.
and seek further help if they wish to.
Yeah.
Sorry, I'm babbling on. Should quickly just go through some of these questions as well. I know you've got a lot of resources up there for people to look at on the handouts, and some people have asked when would those handouts be available.
I will make them available tonight.
Mm-hmm.
So either later tonight or tomorrow morning.
Great.
You can find them through the on the final slide. Let me just go to that. So this where I've got the video. Oh, hang on. Let me see if I can use my laser pointer. I've never used it before. Just here, this site here. If you just go there, that's where the recording will be, and I will either put the handouts there or I'll have a link for you to access the handouts.
And related to the resources as well, just a question about are there any particular resources that you would refer people to in trying to help to engage in conversations with young people about substance use, or that you could give to people?
I think that is a good question. Young people and parents too, quite important to engage with. And actually a good website that might be useful is Positive Choices website. That's not on my list, but I can add it. So that's they've got information for young people, parents and teachers actually. And also another resource that might be useful is Reach Out. And there's also the Your Room. I think I had that on the list.
You did, yeah. And Nicole also mentioned it during the presentation in the chat boxes there, as well as putting up a few extra resources available specifically within that primary health.
Oh, great. Okay. Yep.
Yeah.
So I can add those as well, and before I put them up.
Fabulous. And that is the end of the questions that we have, unless anyone else has a burning question that they want to ask in the next minute before we finish up.
Feel free to contact us by email. The sydney.edu.au address is probably the best one to contact me at. But feel free to get in touch if you have any questions that we haven't covered, or if I've gone too quickly and missed it. And just to point out, I'm very sorry about the cut-off slide at the very bottom. I know that a lot of the references were cut off, so they'll be visible in the handout.
Thanks, Chris, and thank you to everyone for joining us this evening, and look forward to seeing you at the next one. And again, just don't forget to fill out those CBD assessments if you wish to. Thanks very much.
Thank you.